There we go. And we will wait until the noontime hour, which is a minute away. And I've got an introductory paragraph before getting you started. Unless you want to read, Peggy. Yeah.
No, I'll let you can, you're near the microphone.
That's fine.
This is your assignment.
I'm fine.
I did yesterday.
I'm fine, no
And
problem.
Jay gets the swag from his own program. Ombudsman.
How have you been, Greg? You haven't been coming to HGS. Have you given up on us?
You know,
I
truthfully,
practice using the,
my
Sesame Street.
better half and I have been running since March in the evenings, well, late afternoons and after work, and during the hottest part of the year, we tried to wait as late as possible.
Right. I understand
And we do that Monday through Thursday, and I've tried not to let anything get in the way of that routine.
Good for you.
But I'm posting for HGS on
Yes, I
social
saw that,
media,
and
and
I appreciate it.
my
'Cause,
pleasure.
we're going quite well. I mean, we've been averaging more than 30 people at meetings, which was pretty amazing. Now
Yeah.
that we've started meeting in person again.
And I've seen lots of folks interact and share the stuff, especially on the LinkedIn side.
I'm gonna start letting folks into the room.
That's funny. Seth, your computer is showing up in the corner of the,
Well, it's gonna mirror everything I do here.
yeah.
They're on there now.
Yes.
They are
Hey
connecting.
Janet, hey Jackie, hey Yvette, glad y'all could join us.
Hi, welcome.
How are you? Long time no see.
No.
Are you one of his?
No,
Janet?
she's her independent self.
Oh,
Yeah, it's in Gerontological Society. And then everything
It's,
fell apart, so we have to see each other.
welcome.
Good to see you all, and
Glad you made it.
if you already signed in through Eventbrite, great, glad to see you. I figure everybody did. Just in case anybody's just popping in off the street after reading the website, before you leave today, go ahead and just use the sign-in sheet so we can just collect some information. But if you've already registered, we've got you. So no worries as far as that goes. And I am gonna keep letting some folks in as we go along.
Hey Alan.
For those of you who are out there watching us in the conference room here at the Hope and Healing Center and Institute, welcome. And if someone wants to give me a thumbs up that you can hear my voice, that would be awesome.
Hey Jamise,
If you can hear my voice, give me a thumbs up
can you see somebody else on there?
or turn your camera on or all that good stuff to let me know. We can hear.
Yay.
Awesome.
Thanks, Rita.
Thank you very much for that. We're going to go ahead and continue to let folks in. I am the disembodied voice, which is, there we go. You may see my hand waving over here.
Here it is.
And so we want to welcome those of you who are here in the conference room, and we want to welcome those of you who are joining us on Zoom. For those who I have not yet met, although there's quite a few in this crowd that I have, which is wonderful. My name is Seth Stander, and I am the Community Aging Specialist for HHCI Cares. HHCI is the Hope and Healing Center and Institute, our host organization, and HHCI Cares is an acronym that represents the different focuses of our particular program on caregiving, aging, resilience, ethics, and spirituality. We were formerly known as the Community Bioethics and Aging Center and have recently rebranded thanks to the leadership of Dr. Peggy Dittermeyer, who is in the room but not on the camera at the moment. We focus here at HHCI Cares on issues related to healthcare ethics. We offer community programs such as today's Lunch and Learn, our Aging with Grace and Savvy Caregiver series, which we run in the fall and the spring. We facilitate grief support groups. We coach individuals and families on aging and caregiving and grief issues. And we offer guidance in the community through what is called CHECS, our Community Healthcare Ethics Consultation Service. So for this month's Lunch and Learn, we are very pleased to welcome back Greg Shelley, who you can see waving on the camera. He is the Managing Local Ombudsman for Harris County's Long-Term Care Ombudsman Program. And his topic for today is taking charge of your care in a nursing home, suggestions for residents and their caregivers. Now, the Harris County Long-Term Care Ombudsman Program is hosted at the Cizik School of Nursing at UTHealth and is provided in collaboration with the Harris County Area Agency on Aging, otherwise known as the Other AAA. Greg has over 12 years of experience with the Ombudsman Program, contributing initially, as almost everybody I've seen who enters the staff does, at first as a volunteer, then spent 6 years as staff ombudsman and volunteer coordinator here in Harris County, migrated to Fort Bend County, serving with the Houston-Galveston Area Council, covering Fort Bend and Waller County long-term care facilities. And then he returned in November of 2017 to Harris County as Managing Local Ombudsman. Now, Greg enjoys getting to know the thousands of people that he has met along this particular path of his life's journey, educating them about rights and options and helping them resolve a wide range of issues related to long-term care. He has presented on multiple levels, local, state, and national, including the topic that we're going to go ahead and hear from today. We're going to invite, obviously, those here in the room to go ahead and to ask questions along the way, which Greg can choose to answer or defer until a Q&A period. It's totally up to you, sir. Yeah. And we will keep track of the chat on Zoom as well, which is where you're welcome to go ahead and throw out your questions. And we'll see, depending on time, if we have the ability to do more free-flowing Q&A in virtual land. So great to have you here, Greg. Welcome back to HHCI, and the floor is yours. And would you like me to get your slides up? You tell me when, and I will go ahead and get those up for you.
Yeah, I will. Yeah, go ahead. That'd
All
be
right.
Great. Perfect.
There we go.
And you can still see them on your screen.
Well, let's make sure that I actually shared my screen. So, because just because I put it up on here doesn't mean I actually shared my screen. So let's get your slides actually shared by the virtual crowd.
All right.
There we go.
That way we can see any chat coming in too.
Awesome. And as we can see, we can hear, and the floor is yours, sir.
Hey, I think I said hello to the other ombudsman on there. Thank you guys for attending today. And I saw Olivia and Marion come in just recently. I think I said hi to the rest of you. Hopefully you heard my hellos, but appreciate y'all being here. Appreciate being here. Appreciate being in person to do any kind of presentation. It feels like a step towards normal again, whatever that is. Seth did a good job of explaining my past experience as an ombudsman. Just a little bit about my history. I did spend 4 years active duty as an airman in the U.S. Air Force and in another life somewhere way back. And then I spent some time doing hospitality work as concierge, limo driver, bellman, fun stuff during my college years in Denver. And then I spent 13 years mostly in operations management with the Nielsen TV ratings, and then did some volunteering and discovered the Ombudsman Program and wished I'd known about it ever since I got out of high school, because I probably would be doing this work ever since and be a little more wiser and knowledgeable than I am today. But I have been with the program coming up on 13 years. And like Seth said, a good avenue in if you're interested in doing this kind of work. We're not going to make you wealthy by any chance or stretch of the imagination. Seth was one of our staff members for a couple of years and been with the program for about 3 years before Peggy did some active executive recruitment and stolen from me. But I've forgiven her for that since then. It's good to see both of them as well.
I love that term, active executive recruitment.
So let's talk a little bit about the setup of the program. You can go ahead to the next one. It's teamwork, basically. And this year we actually added another level, and I haven't really updated my my slides yet, but the School of Public Health actually chipped in some money this year for us. That's coming from the Southwest Texas Geriatric Workforce Enhancement Program. Dr. Nayak at the School of Public Health Consortium on Aging over there at UTHealth had given us some money to stay afloat with the most staff members we've ever had for a full year, and that's 8, I'm happy to say. And they're also promising some additional funds this coming year as well that should help us to maintain our staff. The other money that's helping us these days, and what helped us get to the 8 level, is having funds from the federal government come in currently under the American Recovery Plan, and some possible promise of some from even the infrastructure plan that's upcoming later this year. So excited about that extra money, really excited about having 8 members on staff. It makes a huge difference, and I'll explain why that's so important later. I try to spend about 20 minutes here on the Ombudsman Program itself, a little history, and then we'll go into the specifics on the importance of care planning and service planning. So key part about Ombudsman Program is to know the word advocate. We're advocates for the folks who live in nursing homes and assisted living facilities, the licensed assisted living facilities. Unfortunately, we don't have any jurisdiction over the unlicensed care homes or group homes, as they're called. Lots of problems with those, hoping that someday there will be some better oversight of those. We have made progress in the last legislative session, some additional Harris County expanse requiring permits for homes. Long overdue, and the city of Houston's been doing it for some years now. Single steps in the right direction, but they definitely need some more coverage in that area. So key word again is advocates. We're not mediators, though you will hear that term thrown around. We are often trained in mediation, and we use those skills to resolve problems, but we are not mediators except in certain specific circumstances, usually involving one resident to another, not the facility side. We are on the resident side of things. We want to educate them about their rights, empower them to do that. Same with families and their caregivers. Make sure that they understand all their options and their rights, and if they need our help exercising those rights, that's what we're there for. More often than not, they're empowered with the information and they take care of business themselves. And that's very helpful. On the bigger scheme of things, you're doing a good job of keeping up with my clicks. Thank you so much. We want to do things like today, educate consumers that the Ombudsman Program even exists. That's the big uphill battle. All the facilities have a posting in there about the Ombudsman Program, or should have one. It's supposed to be in a prominent position. But it's often surrounded by other government documentation, and people don't pay a lot of attention to it. So the best way that we reach out to folks is by making visits to the facilities, introducing ourselves to residents, and getting opportunities to do public presentations, media interviews, and on a larger scale, systems advocacy through the legislators here in Texas in particular for our program. Every county, go in there to the next one. Every county in the country, including Puerto Rico and Washington, D.C., have an ombudsman program. So every licensed facility is going to have representation of an ombudsman program. Different states do them differently. Ours is a very volunteer-driven program, which massively increases our outreach to folks in the facilities and beyond. Some states don't do it with volunteers. They don't have nearly as much of an outreach. I mean, I think they're a little protected because they want just the professional folks doing it. And that might be in some degrees a quality improvement on a few situations, but it's not near the outreach that we get here in the state. And Harris County is the biggest program in the state out of the 28 programs by numbers of volunteers and total facilities. So just in talking about one of the things that we do is we help people choose places to go to get care in long-term care. And there are like assisted living locators out there that do that professionally. They have contracts with facilities. Some of them even have contracts with unlicensed providers. And that's okay. Some of those folks are probably doing a good job. And hopefully those locators are actually visiting those places before they do business with them. And they know that they're a good provider. Some larger ones on a nationwide level very often have no idea about who they're doing contract. They're just happy to take that $3,000 fee and that they get for placing somebody. But the good thing for consumers in that regard is you don't have to pay anything for that service. But again, one individual doing business with a select few versus an ombudsman program that can tell you everything that's available. And even now we keep track of assisted living, the 280 plus that we have, we keep track of how much they typically charge. So when we're talking to somebody that says they only have $1,500 a month, for instance, we're not sending them to the $5,000, $6,000 facilities a month to do that. So we help people choose homes, and that's the best time for folks to call us and get to know us is before they need long-term care. When you're talking the reality of life, we often wait until bad things happen and then we learn the hard way. And that's kind of the skilled nursing side of nursing homes, the Medicare business, transitional rehab. Anybody who goes into a hospital, has Medicare, has been in a hospital for 3 midnights or more, very often qualifies for that short-term service of rehab. It is sometimes people's first introduction into long-term care. And very often they leave the hospital not knowing that they're actually going to a nursing home. They're usually told they're going to a transitional care facility or something like that. Hospitals aren't trying to be malicious in that. It's just the way things get communicated. And then folks get there and realize, hey, this is actually a nursing home. And it can change the outlook. But we can give the full spread. In Harris County, we have 100 nursing homes currently. That's down by a few in recent years. And currently, every one of those has a level of skilled nursing. And a lot of folks don't realize leaving a hospital, for instance, that they can choose where to go in most cases, depending on advantage plans and things like that. But if you have regular Medicare, you don't have to go where the hospital wants you to go. And we help talk about the importance of having family nearby so that you can get that very important support that a lot of folks unfortunately don't have. We educate people on assisted living things and some of the things to understand about licensed assisted living facilities. There is a type C available, but that's an adult foster program. We only have one left in Harris County. So I don't really talk about those a lot. It's not a very common placement. But type A assisted living and type B assisted living cover the spread of them for the most part. Type A, just essentially simplified, is if a person can understand directions and get out of the house on their own, then that's probably type A placement. If a person needs assistance getting out or they can't understand those directions, that's going to be a type B placement. So typically type B is going to be more expensive. They're supposed to be providing a different level of care than the type A. Unlicensed homes, like I said, I've met people in the industry who do it right. They were in nursing home care. A lot of time it's RNs. They realize that they can't give people the quality of care that they want to be able to give in that setting. They decide to go into business for themselves, and they have 3 residents in their home. And that kind of, you got an RN and you got 3 residents and sometimes even additional caregivers. You're not going to get close to that kind of caregiver range in any of them. Same is true for the smaller assisted livings, the ones that are just in your typical residential neighborhood. Lots and lots of those with varying expenses, of course. But one of my favorite conversations with people is when they call me and tell me that their loved one has dementia and is leaving the home, putting themselves in jeopardy. I have to put them in a nursing home. And then you have to break through that stereotype that they have to go to a nursing home, or that nursing home somehow is going to give them better care than assisted living is. And then they learn that there's some really good residential options for dementia care with excellent staffing ratios that you're not going to find in a nursing home environment, and a very home-like environment as well. Of course, that comes with money. When it comes to options for folks in lower income, we have not as many selections as you might imagine, but we have plenty of them to talk to folks about, as well as things like the Money Follows the Person program, where folks on Medicaid can get qualified for the waiver and get Medicaid to continue to pay for care in assisted living. And for a lot of people, that's a much better environment. as well as the opportunity to stay at home with family support and still get care covered through Medicaid. And ultimately, the bonus for everybody who's on the taxpayer watch is that that's a better deal for the cost of Medicaid as well. So it's a win-win. Continuing care retirement communities, I'll just touch base on those. Independent living, assisted living, and nursing home, all on the same campus. In general, that's the best business model. Independent living, pretty good profit. Assisted living, pretty good profit. Nursing home, not so much. Not to say they don't make money. They do make money. They just don't make as much. So that gives a business who has all three of those a chance to do some things with their nursing care that others simply can't. That doesn't mean that all of them are perfect and great. It's a good business model. And if they're doing well financially, they're probably set up to be able to provide better care in those situations. Unfortunately, most of those come with great costs as well. We'll talk about that in a minute. The best thing you can have really is an ombudsman's insight. We visit all these facilities. We know the leadership. We know the general environment from talking to the residents. Sometimes they don't let us help, but they fill us full of information about things that we can provide folks general information to. We will know information about a facility that you're not going to find online anywhere. Although we will also help point you to places and tools where you can help educate yourself as well. Another part of what we do is systems advocacy, public outreach like this. Like I said, media interviews. Unfortunately, the pandemic had a great toll on the folks living in nursing homes, and somewhere about 35% of the total deaths in the end were among nursing home residents. That percentage is continuing to drop, most notably because of vaccinations. And you're not seeing that same rate of death in nursing homes. You're seeing a much higher rate of death from folks outside of nursing homes that aren't vaccinated primarily. So that's changing that percentage a little, but still 35%, that's a huge number of folks that we lost in the nursing homes. That increased, one benefit of that, increased intention on some of the issues that large nursing homes in particular have in terms of infection control. And suddenly the general public was interested in hearing news about that. So guess what? The number of media interviews I got to do during that time was way up. So always excited to help get the word out that way. And then advertising, when we have some extra money, we do some advertising out there, typically in print. Social media, we're pretty active on that. You'll see at the end of the presentation, and Seth, I believe, is going to provide everyone with a PDF copy of it. You can connect with us on social media if you like. It's a good way to stay informed on things related to long-term care. It's also a good way to reach us. Some folks I found different forms of communication, they do better. I have friends that won't carry a linear conversation on email or text, but if I Snapchat them, they're going to talk to me. I have other friends that are actually from folks in the Ombudsman Program that the only way I can track them down is if I connect on LinkedIn. So, everybody has their own different way of staying informed and continuing to communicate. Commenting on legislation, that's the biggest idea in what we do for systems advocacy, right? We try to influence the legislature to do a number of different things. And as you'll see in a second about history, part of that was trying to get more funds for us to be able to cover the many assisted livings across the state, where in history, we didn't have a whole lot of coverage of that. But we had some triumphs and defeats this last time. House Bill 3961 is a bill that required the nursing homes and assisted living to put our information in a prominent spot on their website. Not everybody's caught up to that. It just went into effect in January. That does feel like a long time ago, but in the world of getting all that communication out to all the providers and having them do the right thing, it takes a minute, as they say. And but that was a big win because it's a better chance that folks are going to know about us. Usually these days, when you're mad at a company, you're going to go look at their website and try to find out the corporate people. And hopefully you get to see our link, because for many reasons, we're a good initial source. We talk about confidentiality, but anybody can call us and have a confidential conversation, and we can't take action unless they want us to. The Essential Caregiver Bill, if you remember, in March 2020, we shut everything down. No visitors inside nursing homes or assisted living facilities. Smart move at the time, brilliant move. And fortunately, sadly for the folks in Northeast and Northwest, they gave us warning signs and we were able to calm it early on. Sad part was we didn't stay that way. We kept it for 6 months where they didn't get any visitors. And meanwhile, the death rate increased massively because everybody else in society kind of went back to what they thought was normal at the time that summer. That meant caregivers were coming in contact with the virus more often, and guess what? Bringing it into facilities. And then some of them work in multiple places, and they would go into multiple places and spreading it that way. So it spread easily and really fast. But the hard part was, especially on folks dealing with cognitive issues, including dementia, no caregivers are able to come in and visit them. Ombudsmen weren't allowed to come in and visit them. Regulatory hardly showed up because they were restricted to just specific infection control visits, trying to mitigate the spread of COVID. So ultimately in September of 2020, the governor's order included an essential caregiver was allowed to visit with folks in person. Sadly, by December and January, I'm still hearing from families telling me that the assisted living won't let them visit because they aren't allowed. And that's kind of the uphill thing for ombudsman, trying to educate the consumers that no, as of September, your loved one can have one essential caregiver. Well, that got put into law effective in January as well. The legislature passed a law, and then the voters actually voted it in, that in future pandemic situations like this, folks will still be entitled to at least one essential caregiver going forward. So we won't have that disaster that we had before. The defeat was on generators after tropical, or I keep saying tropical storms because you're used to it, but Winter Storm Uri, we had a lot of folks having to relocate, and that's really traumatic on folks, especially those living with dementia. Not to mention there's something little known called transfer trauma that can cause permanent issues for folks, physically, mentally, psychosocially especially, and not to mention the hazards that go with trying to transport very vulnerable, physically dependent population. As we've learned from previous big storms, the hurricanes in particular, transporting residents from city to city can lead to big tragedies, and we've had a number of those. So we put emphasis on wanting to get the facilities to have generators. Following like Hurricane Ike and those going back to like 2005, things got solidified where nursing homes now have a generator, but it's only required to operate emergency equipment and a minimal lighting to exit the building in emergency situations. What we wanted to get was a requirement for both assisted livings, which many assisted livings have no generator at all, is that it would actually carry the HVAC, heating and ventilation, and cooling in the summer, usually related to the hurricane, because we've learned some lessons from that as well. But so did Florida years ago when they had a hurricane, shut down power to a number of nursing homes, and one nursing home in particular lost tens of residents to heat stroke because they failed to get them to a safe place during that time, and they didn't have the ability to run the air conditioner. So we tried to get that law passed. It's a big uphill because it is an expense on providers, right? Some of that stuff for nursing homes can be covered in the Medicaid dollars, but assisted living, a little bit different story. We'll be back pushing in 2023 for that change. Florida passed theirs after they learned a really tragic lesson. I don't know what the enforcement is like of it, but it is at least a step in the right direction. So we'll be back out there pushing for new rules again come this time around. So quick history on the Ombudsman Program. Older Americans Act essentially incentivized what is the modern day nursing home industry to get in the business and get that Medicaid, get those Medicaid dollars, right? It didn't take the government a few years to figure out they might need a little more oversight. So the Ombudsman Program demonstration project was part of that oversight that was included into that a few years later. And then it was 1978 before they had Ombudsman Program being required in every state. And it was a couple years later before Texas got theirs rolling. And then in 81, assisted living came under the purview of the Ombudsman Program. It took until 1999 before Texas actually started licensing assisted livings. So it's still mind-blowing to me. That's only been 23 years. And for all that time, all of these assisted livings that were out there had no oversight, no regulatory coverage whatsoever. It was a free for all, much the way unlicensed facilities are right now. And then in 2000, that was pretty quick by them, that the ombudsman statute was updated to include assisted living coverage. It took 13 years of advocacy on behalf of the state ombudsman and others across the country. And we finally got our state legislature to give us generously additional funding, which more than doubled our staff. And assisted livings, the 280 that we have now, down from pre-pandemic days as well. They used to see an ombudsman, maybe never. At times there were only 2 of us on staff, and we had 260 assisted living at the time. And we would split up 130 each. And we might visit half of those 130 once in the year. There's a big might. But with the funding the legislature provided us in 2013, we see every assisted living at least once a quarter, and the larger ones at least 7 times a year. And of course, if we meet people with problems or want us to visit more frequently, we do. So they get a presence much more. And then in 2016, very important thing, we've been operating with some assumptions about what the rights of ombudsmen were and what our authority was. That got clarified in 2016 with what's called the final rule. And what it essentially did was bring in to enforcement that we work under federal authority and not under state authority. So that we are a non-mandatory reporter of abuse, neglect, and exploitation. So people have confidential conversations with us. We give them rights, options, and hopefully good informal counseling about what we think, based on their goal, what the next best step would be. And then if they don't want our help, we're out of it. If we were to witness abuse, neglect, or exploitation, we're not required to report it. And we need to have a conversation with the person that's affected to see what next steps they want. Because the reality in life is, just because you called the authorities, your life problem at hand is not necessarily getting fixed. And very often it gets more complicated. So we want folks to have that power to make their own decision. So again, on the not mandatory reporters, very important to understand. Folks join us as volunteers and even on staff with different disciplines that require them to report. And truthfully, as a citizen of the state of Texas, you're required to report suspected abuse, neglect, exploitation of an older adult anyway. But when you're in the Ombudsman program and you're making visits, you're doing it as an ombudsman under federal authority, and you do not do that without the consent of a resident. We have times where you go, oh my gosh, there's so much stuff that we don't report. And truthfully, there is. I mean, if every little piece of what looked like verbal abuse from a caregiver was reported by me, we would have an even worse staffing issue. Leaving that up to the resident, when you have a private conversation with the resident, you go, ooh, is that okay, the way that she's talking to me? She's like, yeah, she's my favorite caregiver. We just been jiving like that for a couple of years now. So why would I want to interfere with that? So same with family members. Sometimes the only family member they have and the only way they know how to relate to each other is by not being very nice to each other, but at least they have that support. And I don't want to get in the way of that either. But we would talk to the resident and find out. On the bigger things, so folks know, not once in my 13 years has somebody said, I've witnessed what I figured was abuse and them not let me take appropriate action. I've had lots of smaller issues involving neglect where the folks just said, look, I'm working through it on my own. I'm going to get it taken care of. I don't want it to get out into somebody's hands. The thing to think about in terms of other professional ombudsmen, like an operational ombudsman at a company or a corporation, the benefit they give employees and truthfully the company is that if you bring us something to an ombudsman, they have to keep it in confidence in that setting as well. But if you brought some things to your manager and you mentioned certain keywords, it's out of the manager's hands at that point, and the manager has to go through this whole reporting process, and you've lost control over a situation. Same with us, except we aren't beholden to the company. We work really hard to keep conflict of interest matters at bay. And so we don't allow anybody that's getting any money from the long-term care industry to participate as a staff member or a volunteer. And we work really hard to protect that relationship because we need folks to understand they can have confidence in us that we're not going to take away their control. Reality is, we've even had a couple of sexual abuse reported, and if it wasn't for the role of the ombudsman and the fact that those individuals knew their ombudsman, one even waited almost 30 hours before reporting it because they knew the ombudsman was coming to visit and wanted to talk to her about it first. And fortunately, in both of those cases, they let us report it appropriately and those folks were arrested. I never get to hear what happens later because the judicial process is not fast, as most of us know. But that confidence, I don't think, in at least one of those cases, I think if the person didn't know an ombudsman and didn't know the rules, they might not have ever reported it. And one little sneaky thing about the ombudsman that a lot of folks don't know, and we seldom have to raise with folks, is interference with an ombudsman is a Class B misdemeanor in the state of Texas. Interference has many versions, some as simple as intentionally covering up our sign, some more malicious, like telling residents not to talk to the ombudsman. But usually the ones we get into it with are ones, as I'm thinking about this, I'm thinking about one of the cases with Seth when he was ombudsman. Is folks telling us we can't visit. We had a number of facilities try to do that after September 2020, when in fact we had the same authority to visit as regulatory did. And some of the folks just weren't informed, and then they wanted to be really hard-headed about it. So that just leaves us, the only option really is ultimately go to regulatory. And if we couldn't get it fixed with regulatory, it might become a legal issue for them as well. So it's good to have that authority if you need it, but we seldom need to bring it up because I really don't want to get anybody riled up if I can get it fixed through other means. I mentioned that every county has one. Ours is the only one, as far as I can tell, that's housed in a university. That's got a lot of benefits in terms of many things. It's a great environment. UTHealth, I love. It's the best place I've ever worked. Cizik School of Nursing specifically, but it's that the advertising and outreach, and just like I said, the getting to participate with folks that have other interests, like the Consortium on Aging, School of Public Health, and all that. Harris County has 100 nursing homes and 280 licensed assisted living facilities. So you can imagine, even with staff of 8, that's a lot of coverage to do. Thank goodness, thank God for volunteers. They are everything, and especially in terms of quality. A lot of times we as staff, we only get to do a lot of quantitative things, and like late in certain months, especially late in the quarter, we're running to get like some minimum things checked off. I call them speed rounds. Whereas volunteers get to visit once a week, often, well, in general, for about 2 hours a week. Some give a lot more time than that and visit more than one facility. Thank y'all very much. We currently only have 52 certified volunteer ombudsmen and 9 interns, and you saw how many buildings we have to cover. So we're always looking for more volunteers. That's low. We've had some struggles with recruitment, as you can imagine, through the pandemic. We had some volunteers that were just fantastic pre-pandemic, and all that time not getting to visit, and also serious concerns about their own health, and knowing that, you know, potentially the nursing home might be a place that has COVID in it. We lost people through that, and some more interest. But now, as we're kind of on this side of whatever the pandemic, not to say that it's over, but we're in this spot that we are now, more people are getting interested in getting back out there and helping, and we're always happy to have them, put them to good use. So what's the best thing you can do if you go into a nursing home? And that's the one I wanted done. Perfect. You're even ahead of me on that. Awesome. Is get to know your ombudsman. The best time to get involved with ombudsman is not after something bad has happened in a nursing home or assisted living. It's before you ever go, because we can talk you through a lot of things related to long-term care. Try to give you our experience and our knowledge and our wisdom about it, and guide you in the right direction about things more than just where to go to get care. But like rest of today's presentation, I'm going to focus on things you can do, particularly in nursing homes, to get the best out of your care, and especially if family caregivers are helping, to be able to help their loved one get that as well. We want you to understand your rights and options, and if you're equipped with those going in, you're going to be a much better advocate yourself as a caregiver as well.
We want to talk to you about best approaches on service planning or care planning. Service planning is the assisted living side. Learning how to report abuse, neglect, and exploitation. We're a great place to start with that, but we don't investigate abuse, neglect, and exploitation. In a nursing home or assisted living, that is the job of long-term care regulation, part of HHSC. But if someone brings a concern about abuse, neglect, or exploitation with us, we have an opportunity to explain all the options, give them likely outcomes, and encourage them to either let us report or they can report. But if they don't want to, then ultimately they can. Just like me, if I can't fix a problem for a resident that's brought a complaint or a family member, I'm going to end up probably having to bring regulatory in. So if you're initially thinking that regulatory is your best route, sometimes it's not. Trying to work through the problem, and if we're dealing with an unreasonable person, having that additional step where we've documented all that, and then having an ombudsman help you file a regulatory complaint that's more likely to get substantiated is very beneficial, as opposed to trying to do it on your own. And one of the most common things that the general public does is report insufficient staffing, because you look at it logically, emotionally, and you go, there's not enough staffing in this building for all these folks. You don't have to be a genius to figure that out. But by rule, there probably is enough staffing. And a lot of times, unfortunately, where rules are right now is that a person pretty much needs to get some kind of harm done to them before you can really enforce a lack of staffing in that situation. They need to know what happened as a result of low staffing. And then ultimately, trying to help you understand what you're paying for, both in assisted living and nursing homes. The next one said things. The two places that consumers can get information specific about long-term care regulation activity in a nursing home, formal complaints that were filed, and the annual inspections that were done in nursing homes. Assisted living are only done every 2 years. Nursing homes every 9 to 15 months. And then any additional complaint investigations would show up on these sites. One is the state site, and it's really not going to have anything on it that I could think of that's not available on the CMS Care Compare one. The Care Compare one will have a PDF version of any recent complaints, as well as their annual surveys. So pretty good information there to look at. But more importantly, it's been upgraded in recent years after many years of advocacy, and they're still working on improving it. And so you can look at turnover rates among staff. You can look at staffing percentages and how that stacks up to a national and a state level. You can see things like a big red hand on the front of their listing, which tells you they've been in trouble for abuse, neglect, or exploitation recently. So great source of information, 5-star ratings. Like you can, from that data that you can also download if you wanted to really get into detailed comparison from facility to facility, you can learn things like 48% of our large Medicaid facilities are 1-star in staffing in Harris County. If you combine 1-star and 2-star, you move that number up to about 80% of them. So there's a select few that have something better than a 1 or 2-star rating on staffing. And what we know about those things, at least in general, huge generalization, is that the lower the staffing is in a facility, the less likely, care is going to go in that direction. Generally, it's a pretty good correlation. But these things don't tell you everything on there. A lot of them are behind by months, maybe 6 months. There may be an ongoing investigation happening right now that's even involving the Ombudsman Program, in terms of, we can tell people, hey, they've got new leadership that you see on there that they only have 2 stars today, but they've got new leadership. And ever since they've been in there the last 3 months, things are moving in the right direction. And what we look for is the leadership responsive to resident complaints? Are they resident centered? So when we bring complaints, are they saying, I don't want to bother with you, or I'm going to ignore you, or I don't have to deal with you? Or are they saying, oh, great, thank you for bringing it to me. Let's work together on some solutions. So that's important information. Great starting point on these sites for folks to kind of do some generalization. The CMS Care Compare also lets you compare up to 3 buildings at a time on their ratings for staffing and quality measures and survey inspections. So the ultimate best advice I can give you when you're going into, and we'll focus on nursing home side of things, is be kind and get people to want to help you. And whatever you do, don't go in and do the opposite. Don't make people mad and don't start fights with them right off the bat if you don't have to, because you don't want to get in a position where they don't want to help you. So I like to say, it's the same. I try to use that principle going to the grocery store, trying to get food at a fast food restaurant. I'm not going to say anything to a person that's going to make them less likely to help me. While I might have some authority as a customer, they also have some power to drag their feet and maybe not deliver the best quality service in any of those types of settings. So the best thing you can do is be kind, be nice, ask questions instead of making demands, and go from there. The second rule, and this is one that we also have to remind ourselves as ombudsmen, before we go to visit facilities, we need to kind of put on our uniform. And for me, this is my work uniform. It's my official ombudsman thing. And it gets me in the mindset, start thinking about what I'm about to go do. And so I'm not carrying all of my other outside baggage with me in there. And I'm there just to give care to people. And that includes the facility staff. I've seen administrators look like they're about to have a nervous breakdown. And, while they might not have been doing a great job, I still have empathy for them. And I want to try to get the best out of every person I can. So if you get your mindset, you can avoid those situations where you go in and blow your top and maybe ruin a relationship that you might need for a long-term period too. Get yourself in the right state of mind. Now let's talk about care planning. And again, it's service planning in assisted living. And assisted living, I'll mention, has only state rules. There's no current federal rules on assisted living. So the rule book for assisted living is like this. The rule book for nursing homes is like this. So there's a lot more oversight and a whole lot less, I'll say, free enterprise capitalism. That's what I kind of describe assisted living at the full spectrum of that. But assessments are the first thing, and that's supposed to be the full assessment of a person's. We're kind of talking about mostly their medical needs when they come into a nursing home. Separate from what the care plan is, the care plan is actually supposed to be resident-centered comprehensive care plan. And that gets more into psychosocial activity needs, idiosyncrasies, preferences. That's very important. Step 2 comes later, within a week of a full assessment. Talk about timing in just a second. Discharge planning is something supposed to happen at the very start of a person going to nursing home. Even if you think a person is going to be there long-term, some of the things that are supposed to be covered in discharge planning are options like that money falls to the person, that after you get in a nursing home, you qualify for Medicaid, there might be an opportunity to go to a less restrictive setting and actually, enjoy it either at home. I have lots of success stories of that. Or like going into I've had one person go into an independent living that catered to folks with disabilities and made the environment work. And then others that have gone to assisted living environments that were more home-like and still be able to be successful and get the care they need. So that's stuff that should be discussed. And there's actually on the MDS, as they call it, that's supposed to be checked, that they're asking people if they'd be interested in going to another setting or, what their plans are. The other part is, a lot of times a person comes in because they've had some injury, and the family, being well-intentioned, is thinking, I would really like you to stay here. But the resident still has capacity to make their own decisions, and they really just want to go back to their home. So they're there to try to get short-term therapy, get stronger, get some of that independence back, and return to their home. And it's ultimately their decision. So we don't want the institution pushing them into, oh, we're going to just make you stay on the long-term in the nursing home. Interdisciplinary care teams, very important, especially on the first care plan. And that's pretty much every professional in the building that has anything to do with the care of your loved one. Activities directors of nursing, sometimes the administrator, but sometimes the administrator is the leader and is just that. They do administration, and they don't necessarily want to get into every individual's care or can't, because it's a very large building. Others in smaller buildings, or it just depends on the person, they're going to attend every care planning. And I think that's a good sign. I would want to be informed as much as possible as well. But it's not necessarily a bad sign if the administrator's not there. But if you need to get something changed and somebody else is not doing it in their role, the administrator is definitely the person you want to talk to. But medical director should be involved in that one. Even maintenance for that matter, housekeeping, there should be some conversation about how to provide care for this individual and what makes this individual the unique human being that they are. Try to get that captured through those interdisciplinary care team meetings. And in family and friends role, people who have friends and family involved in their care, especially in large nursing homes, guess what? They're going to get more attention. And a lot of folks don't like me to say that because they claim they give everybody the same amount of care. But my practical experience does not tell me that. If you're caring for 120 people and these 20 people over here have lots of friends and family involved and they're able to get people's attention, they're probably going to get more attention. And that's the way it goes. Family and friends can be destructive as well. They can come in and destroy relationships. They can step on the residents' rights and desire to be their own autonomous human being. They can talk over the head of mom, who's still here and still a person and can make her own decisions. And they can make the facility staff just not want to deal with you at all if they can avoid it. So, and sometimes it's amazing to me how often I get involved in adult siblings, the scars they carry into their adulthood, and when it comes to taking care of their parents, how much they disagree and sometimes can't even be in the same room together. So it's not always a super positive, but it can be if people start off on the right foot. The ombudsman can be involved in all of that. They can be in the meetings with folks. They can give them advice beforehand. They can debrief them after. For some folks, they just want to know what their options and approaches should be. And we do that, and they don't need our participation. Sometimes they will know in some buildings, we might have a kind of abrasive relationship over conflict we've had in the past with that facility. And they may decide it would be better that we not visibly involved in the care plan. And that's fine too, as long as they're equipped with their options of what they can do. And ultimately, we're a confidant all along the way. And we just want to empower them with rights and options, of course. The timing of these care plans is recent rules finally require within 48 hours of admission, they're supposed to do a baseline assessment. That would be more like medical needs, the medicine, and make sure that that's covered. We find if someone's getting admitted on a Friday night to a nursing home, it's a horrible time in most places, unless you have strong family advocacy coming in the building with you, because a lot of times people hardly even know your name by Monday, even though there is a 48-hour baseline now for them to at least do some kind of assessment. The full assessment has to be done within 14 days of admission. That's kind of still mind-blowing that you got 14 days to do a full assessment of someone's needs, but they do. And then the comprehensive care plan is not required until 7 days. So someone could literally be in a nursing home for 21 days before the staff is fully informed on everything that they need to provide quality care to them. These are also done on a quarterly basis. And then if there's a change in condition, but a lot of families don't realize that they can call for a care plan anytime they want. They don't have to wait for the quarterly. They might not get it that same week, but they're entitled to have one to address care at any time. So a lot of stuff is included, and I won't be able to go through this a lot, but pretty much anything you could think that would make the ability to give care to an individual. Of course, you got medical and physical needs. If it's someone who's not there for short-term therapy and they're there for long-term, they should know about restorative therapy. So just because you're in long-term care does not mean that they should be allowed to sit around and atrophy muscles and lose abilities. If there's a situation where that's possible, like a person's not getting out of bed or they're not getting out of a chair often enough and they're losing the ability to walk as a result, the facility is supposed to provide therapy to at least keep that ability as long as possible. Psychosocial well-being, that's where activities come into play in people's ability to go make visits, go shop, express their independence. Everything else, all the activities of daily living you can think of, anything related to their diagnosis, dental, nutritional, and again, asterisk on discharge planning as well, should be discussed in that very first. And that very first care plan is the potential to be the most important because it gives you a chance to get all the key players' attention early on. And one of the things that's often missed is the resident is not included in the care plan, the family does it on the behalf of the resident, and there's no conversation with the resident at all. Some residents prefer that. And then there's no inclusion of a certified nursing assistant in it. And current rules call for that person to be part of the interdisciplinary team, which is kind of crazy that they wouldn't be included because they're the ones usually giving the most direct care to the individual as well. Some tips on getting the most out of your time. Woo, I'm trying to get the most out of my time today.
You're doing great.
Thanks. Schedule when the resident and the family can be there mentally and physically and be ready to pretend. Be sure when a facility calls you to tell you that there's a care plan scheduled, understand that you don't have to adhere to their schedule. You can make it work in a time. Try to cooperate with their schedule. That's helpful. But also don't get pulled into the idea that your first care plan is going to be 15 minutes. It's going to fit into your time. If you have a bunch of stuff you need to discuss, let the facility know you need 30 minutes, you need 45 minutes, whatever it is. And ultimately, whatever you agree on for that particular care plan, be sure to stick to that time and respect people's time. And also, if you have a group, a full interdisciplinary team present, and you're going to talk for 45 minutes about different issues, and you've already talked about activities, you should give the activities director a chance to get back to their other chores. The same for if you've talked about clinical issues, then maybe the medical director and the nursing director don't need to be in the meeting anymore. If you're just dealing with a grievance over something that's happened with care, maybe the only two people you need for that kind of care plan are the administrator and the director of nursing. But you don't want to take up anybody's time that you don't need to, because time, staff time especially, is probably the most important resource, and there's not enough of it already, so we don't want to waste it. Again, use questions. We do a lot of why and why not, but why and why not will get people's dander raised if they don't really have good foundations for the why and why not. But try to be, I don't know, Socrates, I guess, and ask questions instead of demand, because demanding is not going to get you very far. It's going to lose relationships. And be sure to provide positive feedback. There are positive things that happen. There are positives about every nursing home, even though I could go in and pick a lot of them apart. It's not my business to do that. There's residents that live there and they'll tell you they love living there and they've been living there for a long time. And they do a good job of being successful in the relationships that they have. Table long discussions. If you need a longer discussion, schedule another time to talk to the administrator. Handle some things through email, handle some things through phone at later times. You don't need to have everybody in the audience in the room. And keep in mind, the bigger an audience, the more politics at play, I like to say. You've got more egos in the room, and you've got more likelihood of damaging somebody's ego. And that's not going to get you very far in terms of getting the best out of them in the future. Do everything you can to maintain open and productive dialogues. And as I say, avoid causing permanent wounds in any of those conversations. There are some solid regulations. If you ever need them, you can look them up before to make sure you understand your rights going into a care plan. But don't sabotage the facility, because they get in the habit a lot of time of just doing these like 15-minute care plans, one after the other on certain Tuesdays. So don't come in there with the regulations. Make sure you understand that they understand, get them to understand that you know what's expected out of this care plan, and make sure they schedule it for the appropriate length of time at a time when people can attend. State rules are sometimes in addition to the federal ones, pretty much additional ones. I work off state rules most of the time, the Texas Administrative Code, but the Code of Federal Regulations can also be helpful. A lot of the rules I talked about recently where the changes came in, they came in through the federal regulations, and eventually the state updates theirs, and I believe they have already. Another update is family councils. Great way to have advocacy in a facility and support for each other as caregivers. If it gets started on the wrong foot, it can also turn into an HOA meeting where there's not a lot of sunshine, but you can drive facility change even through a couple of regularly attending family council members. Some of the best family councils I've had have only 4 or 5 regular people representing it. And as long as, and one in particular didn't have any residents there in the building, they used to, but a lot of folks don't realize that the residents can select their representatives, and they can be from the community. They don't have to have folks that are residents there only. But a great chance for folks to get other folks to maybe help you learn along the way, best avenues without having to learn everything the hard way. Also, if you have a well-meaning leadership, it's a good way to bring problems to them and provide possible solutions as well. Great way to move some things forward. On a national level, Advocacy is national consumer voice for quality long-term care. They would be, I guess, the equivalent of the American Healthcare Association or the Texas Healthcare Association, that they are the, I say lobbying group, but they are the folks that push back on attempts at change in it. Sometimes we're on the same page about things like where, especially anything that's going to improve staff environment and staffing in the facility. We're usually on the same page about those things, but the consumer voice is the resident's voice, and they provide training to the ombudsman programs across the country as well. They have caregiver support. They have lots of information for resident councils, family councils, advocates that are on the outside, residents on the inside, you name it. And if you ever want to volunteer and you have all this extra time on your hands, we have a great training program. We have a next class coming up in July. It's mostly, other than the 2 classroom trainings that we do, it's at your time and your generosity. You decide when you go visit the facilities. We have people visit on weekend. We have people visit during the week, and the more you can change it up, the better. Happy to talk to you about any of that. I know I'm pushing my time now to the second. Got my contact information on there in case you need us. Me specifically, if it's something specific to me, that's great. But otherwise, if you call the main line, you've got a better chance of getting somebody sooner. I'm usually pretty fast, but not always. And social media, if you want it, that'll be in the presentation. We'd love to connect to you that way. And then I'm here for questions, but some of y'all may be out of time. And I'll say thanks for having me. Really appreciate the time. Hope we can be helpful in the future. And just so you know, the folks that are here get swag. So something to consider next time if you can make it out.
Well, let me go ahead and say thank you for, you filled the time with incredible amounts of information. I expected no less, knowing how committed you are to not only advocating for residents, but also making sure that staff, certified volunteer ombudsmen, and the greater community are as educated as possible about the rights that long-term care residents have. So it is terrific to have you presenting all of this information. And for those of you here and those of you who are listening and watching, Greg mentioned earlier in passing, and I want to make sure to emphasize it. I don't recall if I said it at the very beginning, but it's worth repeating, even if I did, and especially if I didn't. The recording, the slides from today's presentation, you're all registered through Eventbrite for this program, which means that you will get the recording and you will get the slides after the program is done. And as soon as we give our wonderful staff member, Emily, some oxygen, she's been pouring and churning out recordings and slides this month as we are in full speed with our programming schedule. So look out for those in your email boxes. And
you'll get a 3-question evaluation at the end of this program. So please take 30 seconds to answer it. That's all it takes. And if by chance there are any licensed social workers in the audience who need CEUs, send me either Seth or me an email, and we'll take care of it for you.
yes.
Yeah, it's good to see so many ombudsmen on there. So y'all be nice to me, all right?
And for those who didn't know that the voice speaking about filling out the evaluation, about going ahead and requesting CEUs, that was our director of HHCI Cares, our McGee Fellow here at the Hope and Healing Center and Institute, Dr. Peggy Dettermeyer. And we want to thank everybody who came out today, virtually and in person, and especially not just because you brought swag, but because you brought wisdom. My former boss, Greg Shelley, thank you so much for being here this afternoon.
Hey, Jamise. Hey, Kathy. Thanks for joining. You other volunteers, I said hi to. Appreciate y'all.
We're gonna let everybody get on with the rest of their day. Again, thank you so much, and keep an eye out through hopeandhealingcenter.org, or if you just want to put in hhci.org, you'll get to our website for future events that you can register for through Eventbrite. And we look forward to seeing you throughout the remainder of the month of October. I want to give one
One more
special plug.
plug
Yep.
for October 26th. We have a series called the Weisberger Lectures on Addiction next week at 6 p.m. and it will also be a hybrid program. We're having a speaker from the Menninger Clinic to talk about the social basis of addiction.
Mhm. And I will begin starting next Monday at 9 to 10 a.m. I was about to say p.m. That's an awful time to do a program. The 4-week Aging with Grace session for this fall. So you have time to register for any and all the above. Just go to HHCI and to our website to go ahead and click on events, register through, and we look forward to seeing you again soon.
And I forgot to bring one little accoutrement. It was my my little towel, my rally towel. Go Astros. Woo!
Yay!
Well, we won the game, so it's
That was
over.
good.
Right?
One, got another one today.
As far as we're concerned, it's over. Have a good afternoon, everyone. You take care.